Hey everyone, welcome back. Let's just jump right into it. Today we're diving into part 6 of our 10-part explainer on ICD-10 CM Chapter 15. You know, the one covering pregnancy, childbirth, and the puerperium. We've been untangling some pretty complex obstetric coding, and today is a big one. We're zeroing in on maternal care for fetal issues, plus we're going to master that notoriously tricky O42 category for premature rupture of membranes. If you're looking for precision and compliance in your OB/GYN coding, you are in the exact right spot.
So, here's our game plan for today. We'll kick things off with the overarching rules for fetal and delivery concerns. Then, we'll shift into a super helpful decision matrix for prom. And finally, we'll lock all that knowledge in with a real-world clinical case walkthrough.
All right, Section 1, Fetal and Delivery Concerns. Specifically, we're looking at the O36 through O48 categories. This range is absolutely crucial because it covers maternal care for things like multiple gestations, suspected fetal anomalies, and delivery risks.
Now, the absolute most critical thing to grasp here is the timing rule. As coders, we have to remember that codes O30 through O48 are all about ongoing surveillance and management during the pregnancy. They are literally not meant for those acute, sudden complications that pop up right in the delivery room. Those have their own separate codes we'll get to another time. The magic phrase to remember here is ongoing management.
Let's see how this timing rule actually plays out with some high-stakes clinical scenarios you probably see every day in OB/GYN charts. And believe me, getting this wrong isn't just a tiny typo. Unspecific latency periods or messing up the timing can trigger some major audits and actually lead to massive revenue loss. So let's get it right. First up is intrauterine fetal demise. The code here, O36 4XX0, is really interesting. The description explicitly says maternal care for intrauterine death not delivered. It's the perfect example of our timing rule. If you have a patient at 28 weeks with a confirmed fetal demise who's waiting for an induction, you use this exact code to capture that antenatal surveillance happening before the actual delivery.
Next, we've got fetal heart rate abnormalities. Say a provider catches fetal tachycardia during a routine non-stress test at, let's say, 36 weeks. You're going to use O36.81X0. Documenting this code completely justifies the medical necessity for all that increased monitoring they're about to do. It tells the full story of the care.
And here's a great example of coding for later-stage complications, placental insufficiency. We use O43.103 specifically for third trimester placental compromise. You'll see this a lot when Doppler studies show reduced blood flow, which obviously puts the fetus at high risk for intrauterine growth restriction, or IUGR. It paints a clear picture of the intensive management required for a high-risk pregnancy.
Rounding out this category is O48.0 for prolonged pregnancy. This one is strictly for monitoring and induction planning once a patient hits that 41-week mark with absolutely no signs of spontaneous labor. It clearly explains to the payer exactly why the patient needs more frequent checks or why an induction is suddenly on the schedule.
Okay, let's shift gears a bit and move to Section 2. We're tackling the O42 category, premature rupture of membranes, or PROM. Honestly, this is a massive compliance pain point if you don't fully understand it.
The foundational rule here is surprisingly straightforward, but it completely hinges on your provider's documentation. To distinguish between general prom, preterm prom, which we call P-prom, and full-term prom, you just look at the gestational age of the fetus at the exact moment of rupture. Preterm versus term is literally your very first dividing line.
I absolutely love thinking about this as a 3x3 decision matrix because it makes picking the right code virtually foolproof. Imagine your rows are gestational age, general, preterm, and full term. Your columns track the latency period, so rupture to labor in under 24 hours, over 24 hours, or unspecified. You just find the intersection of those two facts, and boom, you land on the exact correct code family, whether that's the O42.0 series, O42.1, or the unspecified O42.9.
But here's the catch. To use that matrix properly, your providers have to give you the right ingredients. You need the exact gestational age in weeks. You need the precise timing of labor onset after the rupture. Was it under or over 24 hours? And absolutely crucially, you need to know about any secondary complications. Did this lead to chorioamnionitis? Is there oligohydramnios? All of that dictates your final coding picture.
Which brings us to a major compliance checkpoint. If the gestational age is missing, or if that rupture to labor timing is just kind of vague, those are hard query triggers. We cannot guess the latency period, guys. If it isn't crystal clear in the chart, you have to stop and query the provider. No exceptions. It's the only way to stay compliant.
All right, let's jump right into Section 3 and actually apply all of this theory to a real-world clinical case walkthrough.
Imagine reading this straight from a provider's note. The patient presents at 38 weeks gestation with spontaneous rupture of membranes before the onset of labor. Active labor then begins within 12 hours of the rupture. The chart is totally clean otherwise. No secondary complications at all.
So how do we break this down? Step 1, gestational age. 38 weeks, so we know that's term. Step 2, latency period. Labor started within 12 hours, meaning we're safely in the less than 24 hours bracket. Step 3, we consult our mental 3x3 matrix. We go to full-term prom, slide over to the under 24 hours column, and grab our primary category. And step 4, we never ever forget our secondary gestational week code, which is Z3A38.
So the final completely compliant code assignment is O42.0, premature rupture of membranes, onset of labor within 24 hours. And because she's at 38 weeks, this automatically captures the third trimester timing. We pair that with Z3A.38 for the 38 weeks gestation. Together, those two codes perfectly capture the clinical reality.
As we wrap things up today, I want you to really think about this. How are you going to apply the timing rule and that 3x3 prom matrix to your very next complex OBGYN chart? Think about how these frameworks are going to completely take the guesswork out of your workflow, making you faster and way more confident.
The more we lean on these specific guidelines, the better we protect our providers and keep those patient records perfectly accurate. Thank you for watching, and stay tuned for Part 7. This is Decode Healthcare with Harshal.